The recent updates from the NATA on management of the spine-injured athlete have changed. Previously in football, the face mask was removed to gain access to the airway, and the helmet and shoulder pads left on to maintain the spine in a neutral position. The athlete would be transported to definitive care, undergo an evaluation, followed by equipment removal. Today, we recognize that immobilization is not the proper term. Spinal restricted motion is a more accurate term. With the new equipment, loop straps, and helmet design, it's now recommended that the helmet and shoulder pads be removed and a rigid cervical collar be placed to limit movement before transfer. Many EMS teams have reduced the use of spine boards in those injured in motor vehicle accidents and other trauma. However, in athletics, the recommendation is to place the athlete on a spine board for transfer to definitive care. If the athlete is found in a prone position, whether conscious or unresponsive, it is imperative that the athlete be repositioned supine to have immediate access to the airway and chest. Once it's determined that there is a possible compromise to the cervical spine, the lead should request the spine board team. The lead then moves to the head to provide restricted motion. Notice that she crosses her hands on the helmet so that when the athlete is rolled supine, her hands are on the respective side of the helmet. The team works together as directed by the lead to prepare to roll the athlete supine. Arms placed down by the athlete's sides, legs together. On the count of the lead, the team works to roll the athlete up on one side. This limits torsional movement in the spine, gives the team a chance to reposition, and helps control the momentum of the athlete. One side is pushing and the other side pulling, all in one motion, keeping the head and helmet in neutral with as limited movement as possible. Even small athletes may need many hands and support. Ideally, there should be 4 team members on each side. The staff member at the head continues to support the head and helmet, while the other team members turn to their respective jobs. The chin strap is cut, the jerseys are cut away from the athlete's face. Take care to not lean on the athlete's body. Hand off the scissors to a team member on the other side to complete the removal of gear and clothing. Cut the shoulder pad ties in front. If the athlete has ripcord pads, the ripcord can be found and released. Cut or release the clips from the front panel of the shoulder pads and ensure the strap is cleared out from the athlete's axilla region in preparation for removing the shoulder pads. Depending on the type of helmet, the cheek pads need to be released from inside the helmet using a tool with leverage. Tongue depressors taped 2 to 3 thicknesses can be used to twist at the snaps. Some helmets have quick-release face masks that allow quick and easy access to the face and airway. The lead needs to provide counter-pressure to the movements occurring as the cheek pads are released and removed. There is no ideal algorithm as far as the removing of the face mask and then the helmet or the whole helmet together. The key is that the team is practiced and circumstance dictates the solution. If the athlete is not breathing and/or does not have a pulse, immediate access needs to be gained to insert an airway, intubate, start chest compressions, or use an AED. The team member at the head continues to offer calm communication to the athlete, whether conscious or unconscious. The team works around hand placement and receives direction as needed. This is now a critical moment in the removal of the helmet and shoulder pads. A team member positioned at the shoulder rests their hands on the athlete's chest and takes over support of the head and neck from below. The lead then removes the helmet and, with the help of the team at the shoulders, elevates the athlete to clear the shoulder pads. Control of the head and neck is then returned to the lead. A rigid cervical collar is now placed on the athlete to restrict spinal motion. Collars should be sized at the onset of care on the field by the team members in charge of equipment. This is coordinated by the lead with assist from the 2 team members positioned on either side of the head. The athlete is now ready to be placed on the board. There are different methods of placing the athlete on the board. Again, circumstances may dictate the process. In this case, equipment needs to be removed and the collar secured before placing on the board. A 9-person lift is used here. The lead confirms everyone is ready. The hips are the heaviest portion of the athlete, and the athlete should be lifted as one. Overlapping hands and arms under the athlete helps prevent any lag in the lift. The athlete is lifted, and the board is slid until the lead determines the placement is correct. Securing the athlete to the board now begins. The body should be secured first and the head last. When placing the straps, the hip should be secured and then the rest of the body from there. The athlete's hands should be placed in front and secured so as not to slip off. If IV lines or blood pressure cuffs are utilized, they can be left on the athlete. Spider straps are a nice addition if available, as they help direct placement on the athlete. They also can be adjusted to fit the height of any athlete and make securing to the board easy. Once the body is secure, the head should now be secured with bolsters on either side, and then straps or tape. When utilizing tape, fold over the tape so as not to adhere to eyebrows or other facial hair. Secure across the forehead and chin, allowing the athlete to breathe through their mouth if needed. As a final check, ensure all straps are tight, hands are secure. The athlete is now ready to be moved to a gaiter or a transport stretcher. When lifting, use a supinated and overlapped grip on the board to reduce the risk of slipping. If the athlete needs to be rotated on their side due to vomiting or clearing the airway, the lead will direct the team to rotate on the long axis 90 degrees. The athlete can now be placed on a gaiter, gurney, or in the hands of EMS for transport. Next, we review the process for placing an athlete on the spine board who is not wearing a helmet, pads, or other equipment. Many different types of athletes may sustain a cervical spine injury, and the steps are essentially similar, just without the need to remove equipment prior to placing the athlete on the board. When the athlete goes down, remember clearance and permission may be needed to access the field of play from officials. In some sports, the action continues. Once the athlete confirms central neck pain or significant neck pain, the initial plan should be collar and board. Further exam and evaluation may be warranted, but one is never at fault for being cautious. An adjustable rigid collar is used to restrict spinal motion in the neck. These collars usually come in 4 adjustable heights, allowing the athlete to be kept in a neutral position without extremes of flexion or extension. Be sure to secure the position with the locks. Occasionally, the athlete's head and neck cannot be moved to a neutral position due to pain or a physical block. Do not force this movement. Use a towel or a blanket or other blocks and board as is. The lead assumes the position at the head and offers spinal restricted motion. In this case, her ponytail is released so as not to create a flexion moment at the spine. If the cervical spine and head are in a less than anatomical position, the lead should attempt to reposition the athlete into a neutral position. This should be done with caution and slight traction. If the athlete reports increased pain or the lead encounters a block, movement should be stopped and the athlete's head supported in the position found. The athlete's body is now gently placed in alignment to prepare to place the cervical collar on the athlete. Place the collar on the athlete to achieve spinal restricted motion. Again, this should be measured prior to placement. The board is moved into position, and the lead guides the team to placing the athlete on the board in a coordinated fashion with a cadence and affirmation. The body straps are placed. Hips are the first landmark, followed by the rest of the body. It is important that the lead maintain good stabilization of the head while the body is being secured. Remember, secure the body first, then the head. The head stabilizers are then added to the side of the head, and the head is then secured to the board with straps or tape, again, protecting eyebrows, facial hair, and the mouth. The athlete is now ready to be moved to the transport or gaiter with good lifting position and arms and hands overlapped. If the athlete needs to be rotated to clear the airway of vomitus, a 90-degree turn should be performed. There should be no movement of the athlete on the board. If the athlete is prone, the athlete should be rolled supine. The lead must again cross the arms while restricting movement in the neck and head so that when the athlete is rolled, the hands are able to support. The athlete's arms are moved to their side to assist with the roll. Here, the athlete is rolling to the lead's left because the athlete's face is already turned in that direction. In this case, the lead rolled the athlete halfway to her left side and then slid the board in behind the athlete. As the athlete and board are rolled supine, the athlete may need to be centered on the board. The board should be moved to the athlete, not the athlete to the board. So lift the athlete and adjust the board. She's now centered on the board. This may take 2 or 3 attempts to place the athlete appropriately. The rest of the process continues as before. The straps and body are secured, followed by the head. Again, a collar is placed on the athlete, or, in this case, since neutral cannot be achieved, a towel is used to support the head and neck in place.